Assalamualaikum and hi, my name is HAZIMAH binti HISHAM, and together with my fellow group members, we will be discussing a case report on leukemia. Reported back in 2014, a 13-year-old boy was presented with malaise and fever associated with anorexia, pain in both lower limbs, polyuria, polydipsia, which have been on and off for 3 months. On examination, the patient was reported with pallor and bone tenderness. The patient was then referred to the radiology department only to reveal multiple osteolytic lesions in pelvic bones and upper femur. However, there was no organomegaly or lymphadenopathy reported. Provisional diagnosis was made as suspected Langerhans cell histiocytosis (LCH). After further tests and investigation, the patient was confirmed with B-ACUTE LYMPHOBLASTIC LEUKAEMIA (BALL). BALL is a type of acute lymphoblastic leukemia that causes an individual to have many immature white blood cells, known as B-cell lymphoblasts, in the bloodstream and bone marrow. This happens as the body system mistakenly produces immature white blood cells instead of the mature white blood cells that the body needs. The condition causes the disruption of white blood cells' function, as the immature cells are unable to perform necessary tasks such as fighting infections. As immature cells proliferate, there isn't enough room in the body for healthy mature cells, which is concerning as it also progresses rapidly. According to the Leukemia and Lymphoma Society, B-cell acute lymphoblastic leukemia is the most common subtype of ALL, causing 75% of ALL cases in adults. It is also a common type of cancer reported among children, as ALL usually affects B cells in children. Now we'll move to the etiology of the disease.
Hi, I am INSYIRAH and I will continue the presentation with the etiology. The disease starts in child bone marrow, which is the spongy center of bones where new blood cells grow. The leukemia cells grow very fast and crowd the bone marrow, so the bone marrow has trouble making enough normal cells. Some things make this disease more likely, including exposure to high doses of X-rays and other forms of radiation or cancer treatment with chemotherapy. Children with certain genetic diseases such as Down syndrome are also more likely to get ALL. A review of genetics, cells biology and immunology, and epidemiology of childhood leukemia by Graves concluded that B-cell precursor acute lymphoblastic leukemia (ALL) has a multifactorial etiology with two-step process of genetic mutation and exposure to infection playing a prominent role. The first step occurs in the utero when fusion gene formation or hyperdiploidy generates a convert pre-leukemic clone. The second step is the postnatal acquisition of secondary genetic changes that drive conversion to overt leukemia. Only 1% of children born with a pre-leukemic clone progress to leukemia. The second step is triggered by infection. The triggering is more likely to occur in children whose immune response is abnormally regulated because they were not exposed to infection in the first week and month of life. Lack of exposure to these early infections, which prime the immune system, is more likely to occur in societies that are zealous about hygiene, and this would help explain why at present pediatric ALL is seen primarily in industrialized societies. Next is pathophysiology. The malignant cells of acute lymphoblastic leukemia (ALL) are lymphoid precursor cells like lymphoblasts that are arrested in an early stage of development. This arrest is caused by an abnormal expression of genes, often as a result of chromosomal translocation or abnormalities of chromosome number. These aberrant lymphoblasts proliferate, reducing the number of the normal marrow elements that produce other blood cells lines like red blood cells, platelets, and neutrophils. Consequently, anemia, thrombocytopenia, and neutropenia occur, and although typically to a lesser degree than seen in acute myeloid leukemia. Lymphoblasts can also infiltrate outside the marrow, particularly in liver, spleen, and lymph nodes, resulting in enlargement of the latter organs. And that is all from me. I will pass to the next presenter.
Assalamualaikum and good day. My name is SITI AHMAD and I will continue with the next part, which is the clinical feature. From the case report, this patient present with fever, skeletal pain, polydipsia, polyuria and multiple osteolytic lesion in pelvic bones and upper femur. Serum calcium level were raised. Peripheral blood field examination was normal. Bone marrow show presence of blood cell. Flow cytometry indicate B-ACUTE LYMPHOBLASTIC LEUKAEMIA. As for the general sign and symptom of BO, patients are usually presented with B symptoms, which are fever, weight loss, and night sweat. B symptoms are so called because an abnormal staging of lymphomas includes both a number IIV and a letter A or B. A indicates the absence of systemic symptom, while B indicates their presence. Next is bone marrow failure that include anemia, thrombocytopenia, and leukemia. Other clinical features are easy bleeding or bruising with no apparent cause, fatigue, pale skin, dyspnea, and very easy to get infection. Apart from that, they will sometimes feel pain in the bones or stomach and also pain or fullness below the rib. Red or purple spot called petechiae are sometimes can be seen on the patient's skin. In some cases, patient testicle can increase in size. This is due to the presence of leukemic cell in the testicular interstitial tissue. In cases of metastatic cancer, patient may experience organomegaly like splenomegaly or hepatomegaly. This is all from me and I will pass to the next presenter. Thank you.
Hi, my name is NABILAH binti MOHAMAD ARIS. I will continue with lab diagnosis and findings. Based on case report, the X-rays showed multiple lytic lesions in the pelvis and upper femur of both lower limbs. The biochemical parameters showed readings of 156 of alkaline phosphatase, 1650 of lactate dehydrogenase, 5 uric acid, 3.4 albumin, and 14 serum calcium. The hemogram showed readings of 9.1 hemoglobin, 6300 total leukocyte count, and differential leukocyte count showed 69% polymorph, 22% lymphocytes, 2% eosinophil, and 7% monocytes. Bone marrow aspiration showed 92% blast cells with high nuclear cytoplasmic ratio, fine nuclear chromatin, and inconspicuous nucleoli. Fine needle aspiration showed similar blast cells. Flow cytometry of bone marrow aspirate showed positivity for CD34, CD10, CD19, CD20, and negativity for CD7, CD2, CD3, CD13, and CD33. As for the general findings, the white blood cell count showed high, normal, or low, but usually exhibit neutropenia. Infections are common when the absolute neutrophil count is less than 500 and especially severe when it is less than 100. Peripheral blood smear showed circulating blast, elevated lactate dehydrogenase level, and uric acid level. Chest radiograph showed signs of pneumonia. CT scan showed degree of lymphadenopathy. Bone marrow or peripheral blood showed at least 30% lymphoblasts. Flow cytometry showed positive for CD10, CD19, CD22, CD34, and terminal deoxynucleotide transferase. That is all from me. I'll pass to the next presenter.
Thank you for the pleasure, Fatin. Alright, Assalamualaikum and good day. My name is ZULAIKA binti ZAFFRAIN and I will explain the treatment of this disease. This case report states that the patient was treated as per conventional protocol for BALL. So I will explain in general this protocol. Generally, there are 3 phases in treating BALL in pediatric patients. The first phase is remission induction. This phase's goal is to kill the leukemia cells in the blood and bone marrow. This puts the leukemia into remission. Remission means a decrease in or disappearance of signs and symptoms of cancer. Next is post-remission therapy, which includes 2 phases, which are consolidation or intensification and maintenance. In this consolidation phase, it begins once the leukemia is in remission. The goal of consolidation therapy is to kill any leukemia cells that remain in the body and may cause a relapse. The last phase is maintenance. The goal is to kill any remaining leukemia cells that may regrow and cause a relapse. Often in this phase, the cancer treatments are given in lower doses than those used during the first and second phases. Not taking medication as prescribed by the doctor during this maintenance therapy phase may increase the chance of cancer relapse. A relapse is the worsening of a medical condition that had previously improved. This phase is also called the continuation therapy phase. Next, I will briefly explain on the 4 types of standard treatment used in treating this disease. The first type is chemotherapy. Chemotherapy is a cancer treatment that uses drugs to stop the growth of cancer cells, either by killing the cells or by stopping them from dividing. Systemic chemotherapy is when chemotherapy is taken by mouth or injected into a vein or muscle. The drugs enter the bloodstream and can reach cancer cells throughout the body. Regional chemotherapy is when chemotherapy is placed directly into the cerebrospinal fluid, an organ or a body cavity such as the abdomen. The drugs mainly affect cancer cells in those areas. Intrathecal chemotherapy is used to treat childhood ALL that has spread or may spread to the brain and spinal cord. Combination chemotherapy is treatment using more than one anti-cancer drug. The way the chemotherapy is given depends on the child's risk group. Children with high risk ALL receive more anti-cancer drugs and higher doses of anti-cancer drugs than children with standard risk ALL. Next is radiation therapy. Radiation therapy is a cancer treatment that uses high energy X-rays or other types of radiation to kill cancer cells or keep them from growing. External radiation therapy uses a machine outside the body to send radiation towards the area of the body affected with cancer. External radiation therapy may be used to treat childhood ALL that has spread or may spread to the brain, spinal cord, or testicles. It may also be used to prepare the bone marrow for a stem cell transplant. Next is combined treatment of chemotherapy with stem cell transplant. Chemotherapy is given to kill cancer cells in children 3 years and older. Total body irradiation is given with chemotherapy. Healthy cells, including blood-forming cells, are also destroyed by the cancer treatment. Cancer stem cell transplant is a treatment to replace the blood-forming cells. Stem cells are removed from the blood or bone marrow of a donor and are frozen and stored. After the patient completes chemotherapy and radiation therapy, the stored stem cells are thawed and given to a patient through an infusion. These stem cells grow into and restore the body's blood cell. Stem cell transplant is rarely used as an initial treatment for children and adolescents with ALL. It is used more often as part of treatment for ALL that relapses. Last but not least is targeted therapy, which is a type of treatment that uses drug or other substances to identify and attack specific cancer cells. Targeted therapies usually causes less harm to normal cells than chemotherapy or radiation therapy does. There are different types of targeted therapy such as tyrosine kinase inhibitor therapy. This treatment blocks the enzyme tyrosine kinase, which causes stem cells to develop into more white blood cells than the body needs. Next, monoclonal antibodies are immune system proteins made in the laboratory to treat many diseases, including cancer. As a cancer treatment, these antibodies can attach to a specific target on cancer cells or other cells that may help cancer cells grow. The antibodies are able to then kill the cancer cells, block their growth, or keep them from spreading. Monoclonal antibodies are given by infusions. Currently, there is a new type of treatment which is immunotherapy. It is a treatment that uses the patient's immune system to fight cancer. CAR T-cell therapy is a treatment that changes the patient's T-cells so they will attack certain proteins on the surface of cancer cells. And lastly, these are some of the list of drugs approved. And finally, the outcome of the case report. The patient has achieved complete remission, but his bone lesions are still persisting, but his serum calcium levels have normalized. All this patient has to do is maintain and continue his treatment by completing all phases of the treatment and his drug regimen. That is all from us. Thank you very much for your attention.